Good evening, everyone. It gives me immense pleasure to welcome you all to Manthan, Trial Takeaway by Master, an academic initiative by Samarth Life Science Private Limited. Manthan is a unique knowledge sharing platform designed to bring practicing clinicians the most relevant, practice changing evidence from major global oncology congresses, interpreted by India leading expert and masters in the field. Today edition focuses on what's new in breast cancer at ASCO 2026, where rewarded faculty member will share key trial update, clinical perspective, and practical insights that can help translate evidence into everyday patient care. It is my privilege to welcome our program director, Dr. Ashok Kumar Vaid sir, is the chairman of medical and hemato-oncology at Medanta, the MedCity and one of the India's most respected oncology leaders. Joining him is our esteemed guest faculty, Dr. Rajesh Gupta, a highly experienced clinician and expertise in internal medicine, diabetes, and hypertension management. On behalf of Samarth Life Science, I extended my warm welcome to all our faculty members and participants joining us from across the country. Now I hand over the sessions to Dr. Ashok Kumar Vaid sir for opening remarks. Over to you, sir.
Thank you, Dr. Khushi, and a very warm welcome to everyone. Good evening, colleagues. It is a privilege to be here in front of the dedicated group of clinicians, and we gather here to dissect the breast cancer abstracts from ASCO 2026. Every year we know that a mountain of data is churned in ASCO at Chicago, but the real work happens right here. How do we translate the massive clinical trials into our quiet personal decisions that we make every day in our clinics? Indeed, this year's meeting, as happens every year, also offered remarkably many trials. These are practice-informing data across the entire continuum of breast cancer, be it early breast cancer, hormone receptor positive, triple negative, or metastatic breast cancer. So we are seeing a shift in how we approach the treatment intensity. And this year there was a data from the Optima trial that exactly showed us that how to use the advanced genomic testing to safely de-escalate care. And friends, for high-risk luminal patients, we can skip chemotherapy entirely without compromising the 5-year outcomes. They were similar in both the groups, chemo versus non-chemo. We see this philosophy also in the loco-regional management, that the axillary dissection could be actually skipped in certain patients, and we are finally learning when to hold back, protecting our patients' quality of life without giving up the cures at the same time. The therapeutic landscape for hormone receptor positive breast disease is also evolving, and there was data from the selective estrogen receptor degraders. We would be discussing that as well. Triple negative breast cancer and metastatic space has been the focus of intense research. And with the TROP2 inhibitors discussed in the ASCENT-4 also showed that there is benefit, and the PFS2 has become a critical metric for assessing these agents. Our choices are dictated by the options and the tumor biology. Options as of today and tumor biology as of tomorrow. As we open these discussions, let's not look at the hazard ratios. That's what I would implead. And let's not look at the p-values, but let's look at the data in totality, how that impacts the practice tomorrow morning. Thanks everyone for being here. And we hope to learn from each other, and at the end of it, give a better recommendation to our patients in the clinics. With that, over to you, Dr. Khushi, for the continuation of the program. Thanks once again. Thank you, Samarth, and thank you, Dr. Sanjay, for your deep commitment to academics and to the cause which we carry very dear to our hearts. Thank you so much.
Thank you very much, sir, for the wonderful insight. Now, without further delay, we begin with the latest insight into genomic guided treatment decision in nodal positive breast cancer. To discuss key learnings from the Optima Trial 1, invite Dr. Sandeep Kokar sir. He is from Chandigarh. Over to you, sir. Hello, Sandeep sir.
Yeah, good evening, first of all, and respected Dr. Ashok sir, Dr. Sanjay Kamble sir, and other faculty members. Thank you for the invite and giving me the opportunity to present something on which has been on everybody's mind. The Optima Phase 3 data, which is a non-inferiority study in particularly high-risk ER positive, HER2 negative early breast cancer patients, where we
Sir,
usually feel the, yeah,
sir,
please,
sorry to interrupt, but could you please put the slides in full screen share mode?
it's not full
Slide.
screen.
No, sir, slideshow mode. Something opening. Could you please close that mode?
Just a moment.
Yeah.
Let me just see.
So there is option on the right side bottom
So is it
for
now full screen?
slideshow. Yes,
Yes, sir.
it is
Okay.
now.
So apologies for little goof up. So I now hereby present the Optima Phase 3 data where we usually feel the dilemma of extending the therapy as a chemotherapy versus an endocrine therapy in the first line, particularly in a subset like early hormone receptor positive, HER2 negative early breast cancers. So we all know from our insights from Taylor X and RX Ponder studies, where now we have a clear-cut data in terms of node negative and node 1 to 3 positive, where patients who are low RORs, they can be offered only hormonal therapies. So this trial is particularly important because it selected not only the node positive 1 to 3, but it also randomized the patients to taking a step forward to 4 to 9 node positives, as well as grade 3 and a higher tumor size where one could possibly be inclined towards offering chemotherapy in a real world practice rather than giving the hormonal therapy. So let me go to the trial. So this is one of the phase 3 studies which, depending on the genomic analysis of a 50 gene Prosigna test, identifies a patient as a low ROR less than 60 and a high ROR more than 60, and then randomizes them for further treatment to endocrine therapy and chemotherapy. So the trial also highlights the importance of a genomic analysis where we usually uh, guide our patients to Oncotype DX versus a KNSS scores. Now we have another test which is a ProSigna score that can uh, dissect the patients into two different risk groups, whether a low RORs and a higher RORs depending on the scores. So this was the trial design which included male and females to more than 40 years of age, ER positive, HER2 negative, and a high risk population like 0 to 9 node positives, and no neoadjuvant chemotherapy was prohibited. In the control arm, patients were randomized to the patients were offered chemotherapy followed by endocrine therapy, and then the randomization took place between Prosigna high RORs more than 60 and low RORs more than 60 and less than 60. So the patients who were low risk low score of recurrence, they were offered endocrine therapy. With a high RORs, they were offered chemotherapy followed by an endocrine therapy. So the primary statistical design was highlighted as a non-inferiority hypothesis where 3% of absolute non-inferiority margin for IBCFS, that is breast cancer-free survival, was analyzed to highlight it as a non-inferiority trial. So control arm, the treatment allocate the randomized patients were around more than 2,215 and the treatment allocation was around 2,165, which in a real world practice is again signified as 2 to 3% of the patients will again may not be randomized to treatment and they will go for chemotherapy rather than offering the endocrine therapies. So around two-thirds of the patients had ROR score of less than 60. as you can see in the both the control arm and the test directed arms, where approximately two-thirds, that is 66% of the patients had ROR of less than 60. So this is an important slide, which is again important to highlight the high risk population that you can see node positive disease. Approximately 78% of the patients had a node positive disease. 1 to 3 nodes were approximately 74%, and 4 to 9, that is approximately 20% of the patients had 4 to 9 nodes were positive. A tumor size, approximately 50% of the patients had a tumor size of more than 3 centimeters. Grade 3 tumors, again, high risk populations. So that will come to the limitations of the trial also, that it offered only a hormonal therapy, again, plus minus CDK4/6 inhibitors. That has not been taken into account because the trial started in 2017 when the patients were randomized, and at that time endocrine therapy was the standard of care. So approximately 30% of the patients were grade 3 tumors. 60% of them were postmenopausals, and 40% of them belong to a premenopausal subtypes. So if you see the high risk populations, there is a fair distribution of tumor size, node positivity, grade 3 tumors, and a premenopausal subset. So now coming on to the invasive breast cancer free survival events, you can look into the control arm and the test directed arms. There is approximately 7.2% versus 7.3%. And in the control and the test directed arm, you can see those patients who had ROR of less than 60 or equal to 60, where chemotherapy followed by endocrine therapy was given. The events were approximately 68, and the percentage was approximately 5%. And in patients who had a low risk score, they were offered endocrine therapy. The events are approximately 76. So the authors concluded that to prevent approximately 100 recurrences, to prevent approximately 2 recurrences, 100 patients had to be offered chemotherapy. So if you look at the absolute numerical difference, the absolute numerical difference is only 8. The 8 events were more in patients who received only endocrine therapy compared to the chemotherapy versus endocrine therapy in the lower ROR risk groups. So this was an important point to highlight. So the invasive breast cancer free survival, if you look at the complete per protocol population, 1.5% observed 5-year difference, which favors chemotherapy, and approximately 1.2% observed 5 years difference favors chemotherapy. So the non-inferiority is again proved here. So distant recurrence-free survival, not much difference, 0.8% observed difference, which favors chemotherapy. You can see in the per complete, the curves are almost overlapping each other even in a patient with an ROR of less than 60 subpopulation. So again, as per the subgroup analysis, low RORs score population, you can see whether the tumor size more than 3 centimeters. Particularly important point to highlight is PN2 disease. So I would still say that the number of events that happened in both the test directed and the control arm, that is 20 events in the N2 disease and 17 events in the control population in a patient population of approximately 250 to 60 patients, is not that high to take something out of it, that even in patients who are 4 to 9 node positive, they can be offered only endocrine therapy because the number of patients is less. Otherwise, I think if you look at the overall graphs, the curves are almost overlapping each other. So this was one point to highlight. And even if you see the grade 3 tumors, the non-inferiority is again proven. The hazard ratios are approximately to the tune of 0.8. So the intended chemotherapy, again, this trial was not inclined towards highlighting the whether to give them anthracyclines or taxane or a TC-based chemotherapy. But again, if you see the intended chemotherapy that was offered, again, it proves that any of the chemotherapy arm could have been offered. So BCFS was in a menopausal status with low RORs, again in premenopausal and postmenopausal. The hazards are approximately reaching 1.04 and 1.14, and the observed difference lies to the tune of approximately 1.3%. So as far as the nodal burden is concerned, I have already highlighted that in 4 to 9 node positive, the number of populations was less. That is approximately around 18% of the patients were there. and there was 1.6% observed difference, 5-year difference was there. And the number of events, if you look at, it was approximately 8 events more numerically in a population of low genomic risk scores. So in the overall tumor stage also, 2A, 2B, and 3A, the curves are more in favor of giving an endocrine therapy rather than giving chemotherapy. So this was a time-driven analysis when all the patients had been on a study for a minimum of 1 year. So the median follow-up at the time of presentation was approximately 3.9 years, I would say. So the follow-up that has been there is too small to conclude something out of it, whether the patients, because the recurrences in hormone positive population, they usually occur late. So point number one, I think more follow-up is required to derive that conclusion that the patients who are of low RORs with less than 60 can be offered only hormonal therapy, even if the patients have a huge nodal burden. And secondly, the premenopausal females who are less than 40 years of age, they were excluded. This trial predominantly included a white population, which is again underrepresentative of Asian subgroup, and the cost-effective analysis is still ongoing. So the conclusions, Optima concluded that this genomic analysis score goes far beyond what we have seen from TAILOR-X and the other trials, uh, even beyond the Oncotype DX, and it can identify a patient subgroup population. Basically, it is intended towards highlighting the genomic biology rather than identifying the nodal burden. So if the genomic biology states that the score is low, even if the patient is a node positive disease, then probably they will not benefit from chemotherapy. So approximately 2 recurrences will be prevented for every 100 patients, as we have seen that approximately 68 and 76 events were seen if the 2800 patients were offered chemotherapy in a low ROR subgroup. So this 50 gene test can assist guiding us the adjuvant chemotherapy decisions, particularly in the areas what we are struggling, and it has taken a step forward. I think this is a very bold step where uh, even in a patient who is node positive and that goes far beyond more than 3 nodes, again, I would say this is a bold step. So premenopausal females aged at least 40 years treated with ovarian suppression, and patients with 4 to 9 lymph nodes or stage 3A tumors. So acknowledgement were made to patients who made this trial possible. A layout of the summary was it is designed to reduce unnecessarily chemotherapy for patients who are newly diagnosed HR positive breast cancer, and overall 4,400 patients were recruited from over 9 years from 6 countries. And the trial compared the number of breast cancer recurrences and deaths in patients who are treated with standard chemotherapy with those having a chemotherapy decision using made a Prosigna based test. So 50 gene test, it is actually predictive of identifying a patient who can benefit from only endocrine therapy and unnecessarily avoiding the chemotherapy. And I've already stated that this trial is actually a practice changing trial because this provides a very strong evidence that the Prosigna based test can guide the chemotherapy decisions, number one. And number two, it is one of the first prospective randomized trials which actually provides a validation towards a genomic risk analysis in a patient with 4 or more nodes. And thirdly, it also gives us a chance to de-escalate the chemotherapy in a patient where you have a high nodal burden. And it also provides an important evidence towards giving treatment selection, in particularly in premenopausal females with ovarian suppression. So I believe that this will definitely come up in the guidelines as well. So with this, I end my talk. Thank you for all for a patient hearing. Thank you.
Thank you, Dr. Kukit sir, for the insightful presentation. Our next session focuses on evolving role of axillary surgery in early breast cancer. To share the update from the Syncomic trial, please welcome Dr. DJ Vijay sir from Ahmedabad. Over to you, sir. Hello, sir.
full screen. Hello, can you see my slides now?
Very
Yes,
well.
sir.
Thank you so much.
Close kar.
Welcome, sir.
Hello.
Welcome.
Yeah, good evening. I think Dr. Ashok Vaid will remember me
Yeah,
from
yeah.
the days we spent together at Best of St. Gallen.
Yeah,
And also I congratulate all the organizers for having organized this wonderful meeting on the 15th of June, which also happens to be the Surgeon's Day. So even the first study, if you see, probably trends towards doing surgery first in luminal A type of patients instead of considering them for neoadjuvant chemotherapy in some patients. Similarly, this is also a surgical trial where omission of completion axillary dissection in patients with breast cancer, sentinel node, even in patients who had sentinel lymph node macrometastasis. So all this is being done because axillary lymph node dissection carries very high rates of lymphedema, even especially when macromets come positive. Currently, the standard of care would be due to an ALND. So omission of completion axillary dissection in patients with breast cancer and 1 to 2 sentinel lymph node macrometastasis does not worsen survival or relapse rates. Omission of completion axillary dissection results in less arm-related complications, lymphedema, improved arm function, and better health-related quality of life. And therefore, omission of completion axillary dissection in patients with breast cancer and 1 to 2 sentinel lymph node macrometastasis should be the standard of care. The background is, as I told you, that axillary lymph node dissection carries a very high risk of arm-related complications, especially lymphedema and seroma formation. Currently, the standard of care would be to do an ALND in patients who have sentinel lymph node positive. So a previous study was done, which was called the Z11 study. I will point out towards the end of the talk the major differences between the Z11 and the Senomac trial. Uh, they lacked statistical power, failure to include relevant clinical subgroups, and varied in or failed to report nodal radiotherapy target volumes. So the endpoint was overall survival, non-inferiority margin 2.5%. So patients were randomized to completion ALND versus omission of completion ALND and further treatment as per standard of care. So these are basically T1 to T3 tumors because this is very relevant in the Indian scenario because of a lot of our patients would be T2, T3 tumors. And when node negative, obviously, and you do a sentinel lymph node for these patients and they turn out to be having macrometastasis. In our own experience as surgeons with over 3 decades of experience, we find very often that ultimately the 2 nodes or 1 node that was reported on SLNB were finally the only 2 nodes that were final in the final HP, and we have done an extensive ALND and removed additional 28 lymph nodes, and all of them have been reported negative. So clinically node negative either on palpation and axillary ultrasound. This is a major difference where patients could undergo either BCS and mastectomy. So patients in both categories were included in this study. Z11 included patients only with BCS. Questionnaires for quality of life were enlisted. Excellent response rates, 81 to 83%, and post-operative assessment early and at 1, 3, and 5 years to look at survival. So eventually 2,766 patients were randomized. Per protocol population was 2,400. As you can see, they came from different countries, but Sweden had the largest number of patients, followed by Denmark. And we will not go into the details of the other countries who participated in this particular trial. I had the benefit of meeting the author of this paper, Boniface, at the ABS meeting, Association of Breast Surgeons UK meeting held last week at Glasgow. Median age was 61, tumor. If you can see that nearly only 6% of patients were T3 tumors, majority were T2, between 2 to 5. I think this is also in consonance with the Indian population. And about 36% of patients underwent mastectomy, the remaining underwent BCS, and 77% had grade 1, grade 2. 87 of them were hormone receptor positive, HER2 negative, probably a slightly higher figure than what we would see in Indian patients. One sentinel lymph node was positive in 85% of patients, and additional lymph node was positive in 10%. And extranodal extension was seen in 34.3%. Median number of removed lymph nodes was 15 versus 2, and therefore ALND, non-sentinel lymph node metastasis, could occur in about, so you may have a false negative result in about 34 to 5.5% of patients. Adjuvant chemotherapy, patients who underwent axillary lymph node dissection, adjuvant chemotherapy in about 65% of patients. Those who underwent, so both the groups, those who underwent ALND versus those who omitted ALND, they were nearly perfectly matched as far as adjuvant chemotherapy, adjuvant endocrine therapy, adjuvant radiotherapy, and plus minus including regional nodal irradiation as may per the current radiation protocols. Now, when they were compared for the results, the local recurrence was, I would say, almost identical, 1.2, 1.3%, whether you did an ALND, did not do an ALND. Regional recurrence, again, completely identical. Distant recurrence, again, same. Death and by any cause, and death because of breast cancer. Again, I think perfectly matched head to head. So the 5-year overall survival, if you see completion ALND at the end of 5 years, 94% of patients were alive at the end of 5 years. And when you omitted doing a complete ALND, in spite of the fact that patients had 1 or 2 sentinel lymph node macrometastasis, even at that time, 95% of patients were alive at the end of 5 years. Again, they have done this in T3, but please remember that the number of patients with T3 tumors was very small. And majority of patients were T2 tumors. Majority of the patients with macrometastasis were, one was the number of macrometastasis, very few patients with 2 macrometastasis. About 900 patients underwent mastectomy, and around 1600 patients had undergone a breast conservation therapy. For all other subsets, I think they are well matched. So 5-year secondary survival, recurrence-free survival, completion ALND 90%, omission 90%, breast cancer specific survival almost identical, global health, quality of life identical in both, probably better in patients who underwent the omission of ALND than those patients who underwent axillary lymph node dissection. Again, the arm symptoms were better, obviously, as can be seen in this diagram, in patients in whom ALND was omitted than in those patients who underwent an ALND. Physical functions, patients often complain of restriction of arm movement, shoulder movement. Again, that was much better when you omitted doing an ALND than in patients who underwent ALND at the end of 1, 3, and 5 years. So when they were assessed for severe or very severe problems, those patients who underwent completion ALND following 1 node positive SLNB, 12.6 versus 3.6, and this was very statistically significant. To summarize the study, survival after omission of completion ALND is non-inferior to completion ALND. So you can avoid if selecting patients doing a complete ALND if 1 or 2 macrometastasis positive in SLNB. Omission of completion ALND results in significantly less arm symptoms, better quality of life, and better arm physical function. I think this has to be properly discussed with the patient prior to surgery, that I am going to do a sentinel lymph node biopsy in you, and if 1 or 2 lymph nodes macrometastasis, even if they come positive, then I'm going to avoid doing an ALND in you, and you might have to radiate the axilla subsequently as per the AMAROS trial, rather than doing a completion ALND and giving the patient the morbidity of an axillary lymph node dissection. But this has to be properly counseled with the patient. Omission of completion ALND should be standard of care in breast cancer that has spread to 1 or 2 sentinel lymph nodes. This recommendation should be viewed in the context of adjuvant locoregional radiotherapy, which most patients in Senomac received. Now they are doing one more study where they are omitting loco-regional radiotherapy is being evaluated in the ongoing T-REX trial. I thank all of you for having given me this opportunity and a patient hearing. So let me stop screen share.
So, Dr. Vijay, that was as usual a wonderful presentation. And Dr. Khushi, I'll take a couple of minutes here. And very, very pertinent trial where de-escalation has been talked about. So the first two talks have been on de-escalation. And we know historically wherever de-escalation has been attempted, so results have not been as bad in oncology. If you look at lymphomas, the extent of radiation field we were using for Hodgkin's became shorter and shorter. The number of chemocycles for early disease became smaller, numbers shrank, and number of drugs also have been tweaked. And then we have seen for many other tumors. So this is a very welcome sort of a development. So we could probably, if Dr. Sandeep is still on the program, we could maybe have a discussion around these de-escalation issues and then how confident we would be talking about these to our patients. The Optima trial is amazing. The third possibility after Oncotype and Can Assist, we are getting that opportunity, and it's a 50 gene analysis. So if there are some questions, Dr. Rajesh, Dr. Bhavesh, please join the discussion. And if I could request Dr. Vijay and Dr. Sandeep to also join the discussion.
Yes, sir. Good evening, sir.
Hi, good evening.
Yeah, I think the Optima trial and Sanomac trial both are very important trials, and it's a changing scenario in breast cancer. So we are looking for our further discussion also on the various two another trials like Destiny trial and the Ascent trial also.
So any comments from Dr. Bhavesh? From your side, we have two Dr. Bhavesh on the program.
Yes.
Yes.
Bhavesh Palodia is a very silent killer, no?
Sir,
That's why I had started the talk.
no, sir, definitely things are changing, and we have to see how are we going to adapt this change in our practice. So I think it is just matter of time. Slowly, we are also seeing the changes happening, and we are adapting to the changes and advances which are happening.
Dr. Rajesh, your comments about this? I think Dr. Rajesh is okay.
Muted. He's muted.
Muted. Dr. Rajesh, could you unmute? And Dr. Parthasathi, Dr. Soumya.
Yeah, up to 9 lymph nodes they have included in the Optima study. So that might change our standard of practice, because we were giving the full chemotherapy in those patients who have got all these number of lymph nodes present. Now everybody, most of the cases in our daily practice have to go for the genomic study to see whether they are actually low risk or what is the degree of chemotherapy benefit in those patients.
So the anatomy is no more defining, it's the genomics. Dr. Bala Stalin, your comments on that, anatomy versus the genomics, or anybody could take that. Dr. Rajesh?
Sir, genomics is going to be more powerful because that's the in-depth information of the tumor. So I think that is going to be very important information for the treatment in future. So Kushi, can we proceed to the next one?
Yeah, yes, sir.
Okay. Shall I share my screen?
Yeah, yes, sir. Please.
I hope my screen is visible.
Yes, sir.
Okay, right. Thank you. So at the outset, I would like to thank Dr. Ashok Vaid sir for giving this opportunity, and also Samrat, who are supporting this event from many years. And I'll be focusing on the highlights of the year in breast cancer, as many of the breast cancer are subtyped in TNBC, hormone positive and HER2 positive. So I'll be focusing mainly on the TNBC because it's difficult to compile everything in next 10 minutes. So we'll be focusing on the metastatic breast cancer here, which are TNBC. So the standard of care, that's what we were learning right now. That standard of care is changing slowly. And there are newer and better molecule, and combinations of previously known molecules are trying to make their way up higher in the ladder. And now we have new first line candidates, where initially we used to use only chemo plus immunotherapy combination. Things are changing to now immunotherapy plus ADC combination. So let us see how this thing has changed this year in ASCO 2026 and 2025. So we know this accent trial, accent 04, which is a combination of sacituzumab govitecan with pembrolizumab for PDL1 positive patient. And now two more trials have come up, that is Ascent 03 in PDL1 negative, where you give single agent SG, or follow Tropion Breast 02, where Dato-DXd you can use. So let's see this in next few slides. So this is a later ESMO 2025, where Ascent 03 was read about, and this is a nicely done phase 3 trial where SG as a single agent used versus chemotherapy in patients who were naive for MBC, TNBC, and PDL1 negative. So since they were PDL1 negative, so the standard of care is chemotherapy. So here the study design very simple. All naive patient who are PDL1 negative divided 1:1 to receive SG 10 milligram per kg. Mind you, this is given on day 1 and day 8 every 21 days, and followed by standard and randomized versus chemotherapy, which can be taxane single agent or nab-tax single agent or gem carbo combination also. So primary endpoint was PFS. Demographics were quite well matched, so not much difference in that, well balanced. And coming directly to the results, so PFS and OS, as we can see, PFS is mature. Here we have achieved the authors have achieved 38% reduction in the risk of progression or death. And as you can see, the median PFS has increased from roughly 7 months to 10 months. There is a 3 months improvement in the PFS. If we see the 6 months and 12 months value, again, the absolute percentage are better, and it is actually becoming better with the time. Only thing what we don't have a mature result is the overall survival, but the trend is towards positivity. And here something which we have to keep it in mind, that almost 82% patient received subsequent therapy, choosing the experimental arm, that was SG. So either before or after you can use SG, but whether choosing first SG is better or not. So there is some hint from the PFS2, which is definitely better. As you can see, it has increased by 4 months. PFS2 is 14 versus 18.2. So longer PFS2 means that probably SG use first is better. And we can see the subgroup analysis again, whether it is age or ECOG performance status, whether the disease status, whether it is recurrent or upfront metastatic, PDL1 status, whether it is less than 1 or between 1 to 10, or which chemotherapy was selected, whether it is taxane or a combination of gem carbo, or even geographic distribution. Everybody showed that there is improvement with the use of SG single agent versus chemotherapy. Again, coming to the intention to treat population, here again, if we see different subgroups like TROP2, the first, second, third, and fourth quartile. So this is basically the increasing expression of TROP2 on the tumor. And even with the highest quartile or the lowest quartile, the difference was significant. Coming to another subset like BRCA, we always do TNBC patients germline BRCA or tumor BRCA, and whether it was wild or mutant, that made a significant difference, because if even in mutant patient you use, the difference or the delta of PFS was more. it was more than 4.5 months. HER2 stress, again, this is something what we used to do in TNBC patients to find HER2 zero or HER2 low. So if we find HER2 low, we have another ADC called as trastuzumab deruxtecan, which can be used. But when it is HER2 IHC 0, the difference is better. If HER2 low, the difference is just 1.5 months. So these are something what we have to keep it in mind. Top 2 score doesn't make much of a difference. BRCA mutant does better, and HER2 low, HER2 IHC 0 does better. So this will be the best population for him. We can give this option. Coming to another category, another trial in the same category, that is phase 3 Tropion Breast 02 trial. This has again been read last year in Berlin 2025, where a single agent dapotomab deruxtecan or dato-DXd is used versus chemotherapy in patients who are not eligible or immunotherapy was not an option for them. So here again, the study design is simple. Arm A is the experimental arm. Arm B is the investigator's choice. Here, the point to remember is dato-DXd has to be given only once in 3 weeks. So it is 6 milligram per kg once in 3 weeks. Patient profile was quite the way we see in our practice. And key results, as you can see, is showing an advantage in the PFS by 43% reduction in the risk of progression or death. Here there is a almost, you can say, doubling of PFS from 5 months to 11 months with an HR of 0.57. So it definitely made a good difference in the first line. Now, overall survival, if we see again, it is improved by 5 months and the HR of 0.79, maintaining less than 1. And duration of response, you see again, it is better, 7 months versus 12 months. Coming to the subgroup consistency, each and every subgroup is showing improvement. Most of the subgroups are showing improvement with the use of dato-DXd. Coming to the summary of both these trials together, not the perfect way, but you can just understand how these two molecules are working. So the scheduling is simpler in Tropion Breast 02, and dato-DXd probably will be available to us in India within 1 to 2 months for usage, whereas SG as of now, I don't see any hope to get it in India soon. Maybe if somebody collaboration from India happens, it's a different with the Gileads. We don't know as of now. But yes, dato-DXd will be available within 1 or 2 months. Scheduling is better once in 3 weeks. Follow-up is better compared to SG. Median PFS is better. If we see the HR is 0.57 compared to Ascent, and we have a more mature OS data, which is again positive versus for SG. So only thing what we have to look for the side effects, which are oral mucositis and ocular toxicity, where in fact most of the trials are recommending even primary prophylaxis for both mucositis as well as oral ocular toxicity. Coming to the next one, that is Ascent 04. This is a very interesting trial where we have a standard of arm, which is chemo plus pembro as of now, versus the experimental arm where SG plus pembro was the experimental arm. Here again, naive patients who were PD-L1 positive, CPS score of more than or equal to 10, were randomized 1:1 to receive this therapy. And the primary endpoint again was PFS, baseline characteristics well matched. PD-L1 CPS median was almost 60. And coming to the efficacy results, as we can see, the PFS shows an advantage of 35% reduction in the risk of death with this combination of SG and pembro. And if we see the median PFS has improved by almost 4 months plus, 6 months and 12 months PFS also remains higher. Absolute percentage remains very good. If we see the subgroup analysis consistency, except for taxane, age more than 65 and de novo metastatic disease, where having a HR of more than 0.7, usually we expect any HR of 0.7 and better is going to be quite significant. So whether gem carbo combination, no prior IO, because nowadays TNBC are getting IO in neoadjuvant and maintenance setting, age less than 65, good PS, and recurrence if it is more than 12 months. So these are whatever green points are there, those probably will become the best choice, but this is not focusing on that kind of a patient. Overall survival, again, the median OS is not reached in both. So the data is still mature. We have to wait for the final results. And coming to the objective response rate, little better with SG plus Pembro. But usually, I think when we use immunotherapy combination, how long the patient survives is important than just an objective response. Duration of response is better with SG plus Pembro, having a better complete responses, 8 versus 13%, and partial responses were similar. Again, this were again seen at TROP2, TBRCA status and HER2, and all were favoring irrespective of any quartile, it was doing better with TROP2. If we see the wild type versus mutant were better, 16.6 months, and HER2 0 was doing better, 16.6 versus HER2 low, which was 11.2. So we understand that we have new standard of care coming up. We are just waiting for molecules to easily available in India, and I think one of them is definitely available, will be available within 1 or 2 months. So I'll stop here. Thank you for the opportunity.
Thank you, Dr. Palutia. Next, we explored the rapidly evolving management of HER2 positive early and metastatic breast cancer. Please join in the welcoming Dr. Soumya Suresh Pandya from Bhubaneswar to discuss the latest Destiny breast trial. Over to you, sir.
By the time Dr. Panda starts, let me offer a comment. Dr. Bhavesh, that was very, very pleasing to hear your talk. Such a complex data and so much of data. And then you presented it so beautifully. There was no iota of doubt about the superiority of one versus the other. And you made a very pertinent point about the two drugs, the scheduling and the handling. We have had a little bit of experience with SG, and we did run into a grade 3 pulmonary toxicity, and we were using the ocular prophylaxis almost like a routine.
Yes, sir. Yes, sir. We have a trial on Dato-DXd. It's an open label trial. So we know exactly which patients on Dato-DXd, but it is in lung. It is tropion lung trial. And here also they recommend usage of prophylactic mucositis as well as ocular toxicity.
Excellent. Very nice. Let's go
Thank you, sir.
over to the next talk. Thank you.
So I thank Ashok sir and also the Summit team for the opportunity. So my talk will be on HER2 positive in early breast cancer and metastatic breast cancer. So we had three kind of a landmark trials in HER2 space. So one is post neoadjuvant, and if there is a residual disease, that is Destiny Breast 05. Then the second one is improving PCR rate and whether it will be improving overall outcome or not in future. So that is Destiny Breast 11. And the third one is in metastatic setting, improving survival in advanced disease. That is the Destiny Breast 09. Next slide, please. So this is the Destiny Breast 05 trial. And if you look at the eligibility criteria, so they have taken the high risk patients. So patients who were having a residual disease. So post your chemotherapy, if surgery is done and there is a residual invasive disease, so something like we know earlier that we were giving TDM1 in such a setting. So in that kind of a setting, so whether TDXD will be better or not, so that part was looked at. So that was a high risk population defined as per inoperable breast cancer or any operable breast cancer, but axillary node is positive after the surgery. So this was the eligibility criteria. So patients who had a residual disease in the pathological specimen, they were randomized in 1:1 fashion. So one arm is TDXT 5.4 milligram per kilogram, and the other arm is TDM1 3.6 milligram per kilogram, and there are 14 cycles in both of them. So the primary endpoint of the trial was IDFS, and the secondary endpoint was DFS, and other secondary endpoints was OS and the DRFI. Next slide, please. Can we have the next slide? So, the primary endpoint of IDFS, so the delta was 8.7%, and if we look at the hazards ratio, there was a 53% relative risk reduction. So the delta of IDFS is a kind of a landmark IDFS that is improving beyond the standard of care. The standard of care was TDM1, and if you look at the percentage of 3-year IDFS, so it is 92.4%. So that tells us that in HER2 space, it is really improving very fast, and we have crossed the 90% barrier. So 3-year IDFS has improved from 83.7% to 92.4%. And so that shows that the TDXT is one of the options in patients who are having a residual disease after your neoadjuvant and still residual disease there. Then you better choose a TDXT because of this delta of 8.7%. And OS right now is immature, and so no new safety signals were there. Next slide, please. Next slide. So coming to the Destiny Breast 1-1. So this is the neoadjuvant strategy. So in this, patients were randomized patients who were diagnosed as HER2-positive early breast cancer, and they were stratified as HR positive or HR negative. So high risk was defined as patients who were more than or equal to CT3 and N0 to 3, or CT0 to 4 and N1 to N3, and inflammatory breast cancer, basically non-metastatic breast cancer. So they were randomized. These are looking at the options of neoadjuvant HER2 space. So they were randomized into 3 arms. One was TDXT 4 cycles, and followed by THP 4 cycles. So this was anthracycline free. So you have got one antibody drug conjugate, that is TDXT 4 cycles and THP 4 cycles. The other one is dose dense AC and 4 cycles and THP of 4 cycles. So you've got anthracycline here, 4 cycles of AC followed by 4 cycles of THP. And the third arm TDXT of 8 cycles, but this TDXT arm or single agent TDXT, that was closed as per the IDMC recommendation. So we have got the data of TDXT and THP44 and DDAC4 and THP4. So this is the data that we will be looking, and on the patients who were in the study, all of them received either of the neoadjuvant arm followed by surgery, and post surgery they were the PCR was looked at. So PCR, what the difference in the PCR, and the stratification was based on the HR, hormone receptor status. Next slide, please. So if you look at the PCR rates, so the PCR rate in the TDXT 4 cycles and THP 4 cycles is 67.3%, compared to the anthracycline, there is a DDAC and followed by THP, that is 56.3%. So we had a 11.2% improvement in the PCR. So if you look at the breakdown, the HR positive and HR negative. So if you look at the delta part, in HR positive, the delta of PCR is around 9%, a little bit dampener compared to 11.2% overall. We all know that HR positive, the PCR is a bit lower side, but when it comes to HR negative, it was around 16%. But overall, if we look, around 11.2% improvement in the PCR was there. Right now, the EFS is immature. Next slide. So next comes the important trial in the metastatic setting, that is the Destiny Breast 09 trial. And in these patients were HER2 positive, they were advanced and metastatic breast cancer. Asymptomatic or inactive brain mets were allowed, and disease-free interval of more than 6 months from the last chemotherapy or HER2 target therapy in the neoadjuvant setting was allowed. And patients who were endocrine, at least one prior endocrine therapy was permitted. So randomization was done between TDXT plus placebo, and the other arm, that is TDXT alone, and the other arm was TDXT plus pertuzumab, and third arm is the Cleopatra arm, that is the THP. So right now we will be looking at TDXT plus pertuzumab versus the Cleopatra, that is the THP arm. The results of the DBO9 primary endpoint was PFS, and the key secondary endpoint was OS. And if you look at the results of the trial, so median PFS was improved from 26.9 months with THP, from that to 40.7 months. So nearly 1 year of extra advantage in PFS if you are giving TDSP plus pertuzumab. And the overall response rate again 85% versus 78.6%, and CRs were more in the TDHT plus pertuzumab arm compared to THP. So 15% of CR compared to 8.5% of CR in the THP arm. Next slide. So these are the looking at the CRs and the PRs. So patients, 53% of the patient achieved CR or deep partial response. So if we break down that, CR is around 15% and deep partial response were around 36%. And patients who attend a CR and a deep PR, they did better. So that is the response kinetics. So time to best response in CR was 8.4 months and deep PR is 9.6 months. But if you look at the duration of best response, somebody attaining a deep partial response versus patient not attaining a deep partial response, it was 39 months versus 34.8 months, a bit of breaking up of the statistics there. And then patients with best response, the CR was 85% and DPR was around 79%. So that is a bit of stretching of the statistics, but we understand that patients who have a higher CR and deeper PR, they will do better. PFS will also be there. Next slide, please. Next, uh, next slide. So as we have seen, so both in your so DBO 5, DBO 11, and DBO 9, the ADC is making a very sharp improvement in the strides. So right now it has come up in the curative setting or in the early breast cancer space. And so also we are seeing that not only in the HER2 space, but also we are seeing that in the hormone receptor positive metastatic breast cancer. We have seen that HER2 low or ultra low TDXT and dato-DXT are still active, and that again in the later lines Sacituzumab govitecan is also there. So the ADC has crept in the breast cancer in HER2 positive and also in hormone receptor positive patients who are having HER2 low or in later lines in the Sacituzumab govitecan, as we saw also in the TNBC setting in the previous Dr. Bhave's presentation. Also we saw that. Next slide, please. So of the more than 200 ADCs in clinical development, 110 have topo 1 payloads and 60 have auristatin payloads, and some are having a novel payloads. And also we have seen that ADC plus IO, like something like we have seen that in TNBC space also, we have seen that SG plus Pembro in somebody who is having a PDL1 more than 10 and somebody who is having less than, and then again SG is out there. So you have got multiple ADCs in the TNBC and ER positive, HER2 negative, and of course they are in the HER2 positive space. So ADC is going to the future. Next slide, please. So ADCs have transformed the breast cancer management in all subtypes of breast cancer. Next slide. So this is the DBO 11 safety summary. So that already we know that. So patients compared to chemotherapy, TDXT or ADCs are better tolerated. Next slide. So thank you.
Thank you, Dr. Panda. Comprehensive care and extend beyond disease management to discuss the practical role of macular curamine in oral mucositis management. I invite Dr. Jeeva Singh Joseph from Madurai. Over to you, sir.
Sure. Yeah, thank you. Are you able to see my slides?
Yes, sir.
Okay. So thank you so much. Today I'll be talking about the role of micellar recruitment. So all of us know what micelle is. It's basically making the
So, sorry to interrupt.
Hello?
Could you please put your slide on full screen?
Oh, sorry.
Yeah, slide so mode.
Okay. Is it okay?
Yes, sir. It is okay.
So yeah. So today I'll be talking about the role of micellar curcumin in head and neck cancers, primarily focusing on the role of this in concurrent chemoradiotherapy. So from this, at the end of the slides, probably I'll be able to convince you that how curcumin can play an important role in helping patients achieve a good response in head and neck cancers after the concurrent chemoradiotherapy. And I will also talk about how curcumin's benefit goes beyond the points which we've discussed. We all know that the load of head and neck cancers is very high in our area. We know that the incidence of head and neck cancers is very high. It's almost the sixth commonest cancer of the cancers we see totally. In our area, this is probably the second most common cancer in men which we see, and of that 90% is the squamous cell histology. We're slowly seeing a bit of HPV positive oropharyngeal cancers, but the predominant problems are with the tobacco-induced head and neck cancers, which form the commonest load of head and neck cancers, and most of them come in stage 3, stage 4. And the complete response rates after chemoradiotherapy, we all know it's not very great, and we're looking at ways to improve the response to chemoradiotherapy. And one of the armaments in our hand is probably curcumin, which is very close to my heart, because the first clinical trial which I ever did in medical oncology after I finished was in the role of curcumin in head and neck cancers way back in 2006. Because that was the time when we started doing clinical trials, and I had so much of reasoning out for that, for the use of curcumin, and the reason is that curcumin has got multifacets of its medical uses, and I will discuss about all of that in the next few slides. And I think at the end of the discussion, you will all be kind of enlightened about how a simple molecule can have so much of impact in such a difficult disease. And we all know most of the patients who receive chemoradiotherapy for head and neck cancers, especially stage 3, stage 4, because the tumor volume is so high for radiation, the mucositis is almost always there. More than 90 to 100% of patients have mucositis at some point of their time. And the grade 3, grade 4 close is almost half the patients who have grade 3, grade 4 mucositis, which can lead to treatment interruptions. We have seen many patients asking for breaks for radiotherapy because they cannot tolerate the mucositis with whatever medicines which we give, all the miracle wash, the saline gargle, the soda backup, whatever we use, the incidence of mucositis is very high, which leads to treatment interruptions. And we know that treatment interruptions can lead to reduced local regional control and reduce complete response rate, and can lead to residual disease, which can have an impact on their survival and the quality of life. And how curcumin prevents that is what this slide set is all about. And it can also, and we also know that xerostomia has one more complication after chemoradiotherapy, which can have a negative impact on the quality of life of patients in the long run. And the concurrent chemotherapy, which we commonly use with cisplatin, though right now we've got a shortage of platinum, but again, cisplatin has been the benchmark for all chemoradiotherapy. And we know the nephrotoxicity of cisplatin, and a small number of patients, even with the weekly dose, do develop some amount of renal damage. And how curcumin can prevent that will be in the next few slides. And we know that curcumin is an anti-inflammatory molecule. It suppresses COX-2, it suppresses the TNF, it suppresses interleukin-6, and it also has beneficial effect by scavenging the reactive oxygen species, and also activates the NRF2 pathway, which also leads to much better benefits, and I will talk to you in the next few slides. And it also has pro-apoptotic pathways and anti-angiogenic pathways, where it suppressing the anti-angiogenic pathway, and also as a radiosensitizer. So all these things which I will cover in the next few slides. And we know that native curcumin has got a much less absorption. The bioavailability is very less, and the normal absorption with your routine curcumin is less than 1%. And we've modified a lot of things with curcumin by adding piperine, which was the first study which I did when we added piperine with curcumin. And the dose of that is close to around 2 grams per day we are supposed to give. But that increases the absorption of curcumin by more than 20 times. And now we've got the micelle formation, where there is a hydrophilic outer part which keeps the hydrophobic inner safe, passing down the stomach into the small intestine, where at the jejunum and the ileum is where the curcumin gets absorbed. So if the gastric acids digest the curcumin, then there is no, the bioavailability goes down. And there is so much of first pass metabolism, which is also prevented with the micelle formation. So the micelle formation has got two gross benefits compared to the routine curcumin. And the NF-kappa B inhibition is one of the primary aims of using it along with the radiotherapy and the chemotherapy, which sensitizes the radiotherapy and cisplatin to when we add the curcumin. So when we add a micelle curcumin, the benefits are much more, and it also suppresses the COX-2. We know that COX-2 is expressed in almost all head and neck cancers, and the larger the tumor volume, the more the expression of COX-2. And if you can suppress COX-2, the response rates are much better. We did that study along with rofecoxib in 2007, when we did the study for rofecoxib, which is a COX-2 suppressor. And when the curcumin can inhibit both NF-kappa B and COX-2, is something which is much more beneficial. It can also suppress survivin, which can also kind of produce radio resistance to the head and neck, to radiotherapy in head and neck cancers. And we know curcumin can suppress survivin, which can also prevent the radio resistance, and it can also improve the sensitivity to cisplatin by suppressing NF-kappa B, and also by suppressing the JAK-STAT3 pathway. So those two pathways can help in overcoming the resistance to cisplatin when we give along with radiotherapy. and it can also prevent, and the presentation is more for preventing mucositis, and then we're looking at the survival data later on. I will show you the slides. And how mucositis is prevented is by scavenging the reactive oxygen species, which is the byproduct of radiation. So that damages the surrounding cells, and curcumin selectively suppresses the nitrous oxide and the native oxygen in the surrounding cells without suppressing the tumor cells. So thereby it can prevent the mucositis in the surrounding areas without harming or without causing any problems with the cytotoxic effect of the radiation and the chemotherapy. So that is a major advantage of curcumin, which can prevent the normal cells from going in for mucositis, whereas it will spare the tumor cells from being killed by the radiation and cisplatin. And I will show you a few slides about the evidence of that. So this is the spotlight of almost the primary study where we realized that there's a 47% reduction in grade 3 mucositis, but without harming or without having any effect on the chemo or radiotherapy sensitivity. So this was the landmark study to prove that curcumin can be safely given just to reduce the grade 3 mucositis or the mucositis of any form. And the Balliga study was something which was studied with the missile form of curcumin. And this was, I think, one of the landmark studies of the micellar formation of curcumin, which we can see that the reduction of the grade 3-4 mucositis was 34% without the missile curcumin, whereas it was only 8% with missile curcumin. And the onset of mucositis was 2 weeks later compared to without giving the micellar form of curcumin. And the REACH study, this is another landmark study. This is one study where the overall survival is being studied. As of now, there is good data to show that there is no difference in the interim, the local regional control. This is to prove that it is safe. It does not interfere with the chemotherapy or radiotherapy, but it provides benefits with reducing the mucositis. But the overall survival data is still pending. It is being analyzed. I think in the next few years, we should be able to get that, because the CCRT completion rate was 94% versus 78% in the control group, which is a very important factor, because patients who could not complete the radiotherapy will not do well. So that is something, but then the salvage surgery, all that will come in. So we will look at the overall survival data in the next few years or so. That will be that may provide much more insight into how curcumin can help us complete the course of radiotherapy for all patients. And this is a summary of many slides, many trials which have been done. The first few, the initial bits were with curcumin and piperine, and then we've got the micellar formation, and then we've also got the mouthwash. So that also can be effective in certain situations where it can prevent the local mucositis to a large extent. And this is the Advair study, the other pilot study, which was important to say that the grade 3 or 4 mucositis duration was much less with curcumin, from 39.7 to 17.1, and any mucositis from 92% to 51%. So that is a major finding in this study. And you can also see that the dropout rate was much less with curcumin compared to without curcumin, which will also tell us about the OS later on. And this was a nanomicelle formation, the study done there, which also shows that 100% of patients without curcumin developed mucositis at week 2, whereas only 32% developed mucositis at week 2 when they were given curcumin along with radiation with chemoradiotherapy. And again, the next study is on an adjuvant basis. That also showed benefit. And this was the trial which on the left side shows benefit of using the local form of curcumin. That also can reduce as you can see, the TNF alpha and the IL-6 levels when they could study the secretion of these two inflammatory cytokines after exposure to curcumin. And on the right side, you can see that, as I had mentioned earlier, survivin level can also be reduced with curcumin. So this is something which is very important, which can prevent the radio resistance and the chemo resistance in head and neck cancers, which are generally large when they come to us in our practice. And there's a logical sequence where when there is mucositis, there will be treatment breaks, there will be dose reductions, and that will lead to reduced local regional control, and again that will help, that will that will cause progression of disease, or the patient may not respond well, and this can be broken by using curcumin. The major side effects of curcumin is primarily probably a GI upset, especially when we add with piperine. But then there's very less, and I think in our study, when we had for 50 patients, not much of side effects that we see. And I think the general side effects are much less. The only thing which we need to be careful is when you are using with warfarin, because it can interfere with the dose of warfarin, but then the incidence has been found to be less than 2%. Quite rare, but still we need to keep that in mind if the patient is taking warfarin. The only problems with curcumin as of now is that there are no phase 3 randomized control trials as of now with looking at the OS data. Hopefully, the REACH data may come soon, and that may tell us about the OS benefits, because that is a wonderful trial, wonderful study. And because most of the studies which we have done were all looking at the mucositis prevention, so that has been proved beyond doubt. But now OS data will come, which may help us identify the benefits of using curcumin. And how should we give curcumin? We should generally start at least a week before starting radiation, and then continue for at least a month after completion of radiation. And the nanomicelle formation is around 80 milligrams BD. You should be taken along with meals, because a fatty meal can help in the digestion or the absorption of curcumin at the in the small intestine. And the only thing is that not much of documentation has been done. Most of us prescribe curcumin as adjunct, but that should be documented, and hopefully we should have more presentations in the long run. This is the last news, I think the last slide. How it can help. There are some data about how curcumin can help suppress the Tregs and can help in some immunomodulation. But then those are they are so far not yet clinically done. There are preclinical, but some data has been shown to have additional benefit of curcumin with immunotherapy. But there is one study to say it can be adverse. So the hope that may come soon. And the benefit of curcumin has been slightly better in non-HPV positive head and neck cancers, because they are the ones which have got higher NF-kappa B. The HPV positive cancers have got less NF-kappa B, so the benefit of curcumin may not be the best. So you can select patients accordingly in your practice. So I think this is the last slide, and I think in the future we may see more use of curcumin because of its NF-kappa B suppression, of its COX-2 suppression, of its survivin suppression, and TNF alpha and interleukin 6 suppression, which can all help in reducing the tumor load and can improve the radio and chemosensitivity in especially head and neck cancers, and other cancers also being tried. And my topic is for head and neck cancers. Thank you so much.
Thank you, Dr. Jiba Singh. That was a wonderful exposition, and many compliments for your great insight and your work. And I think a lot to learn from you. And Dr. Khushi, is there another presentation?
Yes, sir. We have our next session explore an exciting fortunate in oncology to discuss the expanding role in GLP-1 receptor antagonist in breast cancer. Please welcome Dr. Bala Estelin Chaudhary from Visakhapatnam. Over to you, sir.
This is Dr. Bala. You have a unique distinction of, one of the first guys to discuss such a sensitive topic. And we are being increasingly asked in the clinic.
Thank you, sir. Thank you.
By our current patients and those who have completed their treatments, that can we use this drug? And till yesterday, till I attended this ASCO meeting, my answer used to be, I'm not informed enough to guide you about that. And I'm not a specialist on GLP-1, but let's learn through your presentation and get more informed, and so we can talk to our patients more confidently. Thank you so much.
Sure, sir. Thank you, sir. Thank you. Good evening. Thank you, Ashok sir, for this opportunity. Over the next 10 minutes, I'll be dealing on tackling obesity after a breast cancer diagnosis, because we all know that obesity is one of the most common thing which is a risk factor for breast cancer, and also the obesity post-treatment also increases the chance of recurrence and the second primary breast cancer. So how tackling this obesity after a breast cancer diagnosis especially from the behavior change to understanding the potential mechanism of action of these GLP-1 therapies, which I can say that there has been a rampant use of this for the tackling the obesity in normal population. So how using these GLP-1 drugs tackles the obesity after breast cancer diagnosis, whether they are useful in reducing the recurrences and improving the quality of life of the breast cancer patients, we'll see for the next 10 minutes. And this is a common thing. So as Dr. Saying that, so is a scenario that after cancer diagnosis, many patients, but they're still gaining. And many of their friends, many of their relatives now started using these GLP-1 drugs, and these drugs used by my friends and colleagues, many people, and they have a very significant reduction of the weight without much morbidity and side effects. So is that patients will ask to you that, is that something I could try? Is there a research on the effectiveness of these medications, especially in the breast cancer patients? So we all know that the weight gain after breast cancer is quite common. So there is a significant data to say that these weight gain can happen in a very good number of patients. And as the time passes on, so from 3 months to 5 years, there can be a significant increase in the weight gain. And these can be because of the chemotherapy induced menopause or endocrine therapy, what we are using, or the reduced activity, or the emotional stress, or aging. And several studies also had shown that these weight gain is associated with increased recurrence risk and higher BMI is associated with overall. Similarly, as this is relevant in the ER positive that compared to the TNBC and compared to the
voice is cracking in between.
to new positive disease, it's common in our why this obesity is because we all know that obesity hyperinsulin increased estrogen production from the adipose tissue. So all these put together stimulate the breast cancer growth. So what is the various lifestyle clinical trials in breast cancer has taught us? So these are the two trials, the the Women's Intervention Nutrition Study. So this study has taught us that the dietary intervention
Dr.
has
Bala,
reduced the
Dr. Bala, your voice is cracking. May I
nutrition,
suggest you switch off your video?
has reduced the fat intake, and some are there, but the benefits, that is the diet. So which is a lifestyle result is the weight difficult to sustain, but it is difficult to sustain. So both these studies had shown small weight reductions, mixed survival results, and but they have shown that some form of lifestyle changes, some form of weight loss is
Dr. Bala, can you hear me?
helping the patients in reducing.
I think there is a issue with the internet at his end. If he could switch off his video, then audio could come off much better. Let's wait for him to join back. And in the meantime,
Dr. Bala is back. He's back.
Yeah. Dr. Bala.
Sir, I have just spoken to him. He is doing that.
Okay. Just advise him that switch off the video. His.
Sir, yeah, I have spoken to him.
Is it okay, sir, now?
Yeah, much better. Yeah.
Okay. So these GLP-1 drugs, so we all know that, so these GLP-1 receptor agonists, so they act at multiple levels. So they especially they reduce the gastric emptying. So they increase the insulin secretion and decrease the glucagon. And in the adipose tissue, they promote the weight reduction. And ultimately, it helps in reducing the lowering the calorie intake. And ultimately, the patient achieves a significant weight loss. Rajesh, I hope my voice is clear now.
Yes, perfect.
Okay. Thank you. So there are certain clinically approved GLP-1 receptor agonists like liraglutide, semaglutide, tirzepatide, and various others. And they have been shown that at approximately 5 to 6 months of use, there has been a significant amount of weight loss.
and they are usually given some drugs like liraglutide are given once daily, semaglutide is given once weekly, and tirzepatide is given once weekly. And various trials in the obese patients and the type 2 diabetes patients had shown that this will lead to a significant decrease in the weight without much toxicities in the population. So this is the impact of GLP-1 drugs on weight loss. So the BMI reduction will be significant, the diabetes will be weight controlled, and the 6-month, 12-month weight gain and weight change is significantly better with the use of these drugs. So in the breast cancer patients, survivors, patients receiving GLP-1 therapy, they have demonstrated there is a significant BMI reduction, significant weight loss, and these benefits are regardless of the endocrine therapy. So weight loss occurred even in women receiving whether the tamoxifen or aromatase inhibitors
credit card na lakha, go taxi
or aromatase inhibitors, which are traditionally associated with the weight gain. So GLP-1 drugs still appear effective despite endocrine treatment. So what is the effect on the survival? So the majority of the data as of now is coming from the retrospective studies, and they suggest that in terms of the disease-free survival, there was a trend towards improvement, and overall survival, some studies show that there is a lower mortality, better overall survival, and one large cohort of patient which included almost more than 20 to 30,000 patients had shown that. So the hazard ratios are 0.66. There was a 34% relative reduction in the mortality. But the important thing is these are all retrospective studies. There is no prospective study which was published or presented as of now. There were potential biases like patients may have better healthcare access, better adherence, better socioeconomic status to receive these drugs. Ultimately, a lot of confounding may have happened. But as of now, today, the retrospective data had shown that there was a significant weight loss, whatever may be the concomitant endocrine therapy, like whether it is a tamoxifen or aromatase inhibitors, there was a significant benefit in reducing in improving the overall survival and the progression-free, the disease-free survival. But this association is as of now promising, but not there was no significant prospective data and full proof to say that these can definitely improve the survival. So some part of this survival benefit can occur by reducing the other hazards of obesity also, because by reducing the obesity, we all know that obesity is a risk factor for many other cancers. So not only the breast cancer, they can reduce the other cancers also. Also, they reduce the lifestyle diseases like diabetes, hypertension, cardiovascular disease, and also the cerebrovascular accident. So all lifestyle diseases also reduce, which ultimately lead to significant amount of morbidity and mortality. So those impact also happens in these patients in reducing the mortality associated post breast cancer diagnosis. So these are the impact of GLP-1 drugs on the adverse effects of the endocrine therapy. So not only the mortality benefit and the disease reduction benefit, so also this happens the reduced side effects which happen. So if you see, these are the impact of GLP-1 drugs on the adverse effects of endocrine therapy. Both tamoxifen and aromatase inhibitors we know are known to cause lots of side effects like joint pains, depression, hot flashes, and osteoporosis. By by using these drugs and maintaining an ideal body weight, so there was a decreased incidence of joint pains, depression, hot flashes, which are associated, which are most commonly because of the postmenopausal symptoms, osteoporosis. Also, by decreasing the obesity, the chance of having the endometrial cancer with the tamoxifen is also reduced a bit, which was statistically significant. So these are the adjuvant GLP-1 trials. So these are the trials which are being prospectively evaluated, like the FitWise trial and the TRIM EBC trial, where tirzepatide for 2 years was used once weekly post treatment. And once the data from these trials will come, so we can know that whether these drugs which help in evaluating the weight loss, body composition, adherence, and the quality of life. And also in the TRIM EBC trial, there was the data was also looking at the ctDNA clearance, weight change, and the disease outcomes. And this is particularly exciting because it also incorporates the MRD assessment. Once these trials come, results are out, and had shown significant outcomes. So possibly this becomes one of the standard of care in the breast cancer also. But as of now, we should all remember that there is only a retrospective data which is convincingly showing that there is a significant reduction in the disease recurrence and also some overall survival benefit also. But the prospective, we need to wait till the prospective data comes. So weight gain is common after breast cancer diagnosis and associated with worse prognosis. We all know that lifestyle interventions result in modest weight loss, but this is very difficult to sustain. So even for the normal population, once weight loss is there, but it is difficult to sustain. A lot of time and stress need to be taken to sustain this weight loss. And GLP-1 use in patients with breast cancer is associated with modest weight loss, improves overall survival according to the retrospective studies. But the prospective studies are ongoing. Randomized control trials are needed, but will be challenging to design because of lot of issues. So this is the research which was presented at poster at the ASCO 2026. Thank you.
Thank you, Dr. Bala Stalin, for that wonderful exposition. And this is a new topic, as I said in the beginning. And we also know at the same time that 20% of the cancers are going to be associated with obesity, and WHO has already given an alert on that. And so of the modifiable factors and preventable factors is a lifestyle, and obesity is a key there, and also benefit from many other diseases. So we still have time. Any questions, comments, or any discussion points by the faculty? I think let's have some pertinent questions. Or so, Dr. Khushi, unless there is another presentation.
Sir, we have one panel discussions.
Please go ahead.
Okay, sure, sir. So thank you, Dr. Bala, sir. We now move to the highlight of the evening, our interactive panel discussions on multidisciplinary care models and treatment-induced metabolic dysfunctions in breast cancer. It is my pleasure to invite our moderator, Dr. Bhavish Parekh, sir, from Ahmedabad, and joining him on the panel are Dr. Vijay Sethi from Bangalore, Dr. Kausal Patel from Surat, Dr. Rohit Pai from Bombay, Dr. K.M. Parthasarthi from Delhi, Dr. Chandrakant MB from Kolkata. Dr. Parekh, over to you.
Thank you. Am I audible? Thank you, Dr. Ashok Vaid, and thank you, Samad Pharma. This is a very interesting topic, and as Dr. Ashok Vaid also says that it is a very new topic. Ultimately, what to do and how to do, this is also very important. So finally, in recent ASCO 2026, it was presented like association of GLP-1 agonist with breast cancer incidence in women. So what ultimately key takeaway points or conclusion of this very important message is exposure to GLP-1 agonist was associated with 30% reduction in breast cancer incidence in a retrospective observational study. This is very important. The observational studies are hypothesis generating. They do not demonstrate causality, and the preliminary data support a prospective trial to evaluate GLP-1 agonist as cancer prevention drug. So over to my panelists, over to Dr. Chandrakant or Dr. Kausal. Are you agree with this key point or conclusion of this trial?
Yeah, so sir, these are the retrospective and observational studies rather than any prospective phase 3 studies. But to a certain extent, as per data, we can say that the drug is very promising in reducing the incidence as well as to a certain extent protection in breast cancer patients. But we need some solid prospective data, as in third points. We need prospective trials which has certain age, which shows that the GLP-1 agonist having a cancer prevention, or it has incidence in reducing the breast cancer or any other cancer.
Yeah, Dr. Parthasarthi, please. Any comment on this?
Yeah, these are all, like you said, hypothesis generating only because we don't know uh, how they are increasing the OS. Are they reducing the mortality because of the other factors like cardiac mortality or prevention of strokes, which are unrelated to the breast cancer related mortality? and how long these drugs have to be given, and in which all stages it is going to increase the OS. It's all very difficult to calculate with a retrospective study. So it's an interesting observation, and we need prospective data.
Perfect. So why this question matters? Because the breast cancer remains the most common cancer in women worldwide. And the excess weight is one of the most important modifiable risk factor for the breast cancer. The intentional weight loss has been shown to reduce the breast cancer risk, especially after menopause. And GLP-1 receptor agonists lead to substantial weight loss and improve metabolic health. The impact of this GLP-1 receptor agonist on breast cancer incidence remains uncertain. Uh, Impact on the incidence remains uncertain, but lead to substantial weight loss and that improve the metabolic health. So finally, a important question is that there is a definite high prevalence of obesity and breast cancer. There is a large public health because it impact if risk can be reduced, and GLP-1 receptor agonist has been widespread use. Dr. DG Vijay is also there. DG Vijay, doctor, your comment on this particular, because why this modifiable risk factor for the breast cancer and what is the importance of GLP-1 receptor agonist? Dr. DG Vijay? Not there. Dr. M.V. Chandrakant, sir?
Hi, sir. Good evening.
Yeah.
So, sir, one thing what we can note is the magnitude of benefit this GLP-1 antagonists, agonists are giving is phenomenal. I was just looking into the benefit, it is 13% absolute benefit in HER2 positive and 20% benefit in TNBC. Even though it's a retrospective study, the magnitude of benefit is huge in the early breast cancer setting.
Correct.
I'm sure that this will be prospectively looked into. But as of now, today, if a breast cancer patient is there and wants an anti-diabetic, especially if they are obese, I would prefer a GLP-1 agonist at this point of time. I would not hesitate not to use these drugs because these drugs are safe and maybe they have some positive outcomes on breast cancer.
Perfect. Very good comment or real expert comment from Dr. Chandrakant. And the point my here is again that why GLP-1 receptor agonists may influence the breast cancer risk. And the importance is whenever the first is reduce body weight, the body weight reduction, it reduces the breast cancer risk. Like evidence is there that bariatric surgery, it lower the risk of breast cancer 0.56. Again, confidence interval is very important. The second point is that it improves the insulin resistance and metabolic dysfunction. The third is it reduces the systemic inflammation. And the fourth is effect there was on the cellular metabolism and the tumor biology. So these four ultimately breast cancer risk has been reduced. So now this slide is very important that if we identify the initial population from 22 to 25, there are total 2,17,600 unique women who underwent breast imaging. After that, the women between 45 to 80 years, it was 1,66,000. And women with BMI more than 25, it is 1,11,646. So now, if we look this demographic summary of the whole, that how many had breast cancer, how many had breast density, what is the BMI, what is the age, and various ethnicity, and if there is type 2 diabetes, yes or no. So if there is a type 2 diabetes, as Dr. M.V. Chandrakant told that if patient is already obese, then I am not hesitating to use the GLP-1. So even here, the patient among this demographic or 1,11,000 population, the type 2 diabetes is already in 17.6%. So it's very important. So now the comorbidity summary, there is a heart disease, there is a renal disease, there is a liver disease, there is a breast cancer and various cause. So this is also very important that if there is a 3 to 4 means is a high risk score, then again if there is no GLP exposure and there is a GLP exposure. So again, overall it was a 14.6, while in 5 plus or very high, it was 11.7% of the GLP exposure. Now again, if we look this, that after this 1,11,000 patients with BMI more than 25, the propensity score matching is 1:1. And for that, this match analytic cohorts, if we look one match control per case and use for the outcome analysis, ultimately there was a 15,000 match pair has been identified. So this is the final analytic cohort. And in that, again, match analysis or that 30,000 patients of the various BMI class and the age group. And finally, this is the before and after matching. And now the important is the observed association between GLP-1 agonist use and breast cancer risk. So again, if we look in this, the table 3 and table 4 is very important, that if we use GLP-1, if we not use GLP-1, again, there is a cancer 1.62. If no, it was 2.60. So in unmatched analysis, the GLP-1 agonist exposure was associated with a lower incidence of the breast cancer. And even in the match analysis, the GLP-1 agonist exposure was associated again with a lower incidence of the breast cancer. So the key takeaway is both unmatched and match analysis show that the prior use of GLP-1 receptor agonist is associated with statistically significant lower incidence of the breast cancer. The absolute risk reduction, again, the conclusion is GLP-1 receptor agonist exposure is associated with absolute reduction in the breast cancer risk, especially in the match data set. So finally, my conclusion or my interpretation is that in this large propensity score match cohort, the GLP-1 receptor agonist use was associated with significantly lower odds of breast cancer. The consistency of the unmatched and match analysis suggests that the observed association is not fully explained by the measured difference in key baseline characteristic. This result add to emerging evidence that GLP-1 receptor agonists may have benefit beyond glycemic control and weight loss, and that include the potential roles in the cancer prevention. So these slides or the lay summary slides, that what did this research tell us? Chandrakant, my answer was the GLP-1 medication may help lower breast cancer. Are you agree? Who are overweight, but this has not yet been proven.
Correct, sir. Perfect.
So now the second question is to Dr. Kausal, that really who does this research impact? Means women who are overweight or obese is the target audience, Dr. Kausal?
Yes, sir. Yeah. So the women who are overweight, obese with malignancy.
Perfect. Dr. Rohit Pai, any comment on these both questions about the this research or the conclusion, or who should be this research or should be impact on which type of patients?
So, sir, I do believe that patients who are significantly overweight or who have significant comorbidities like diabetes, which is sort of not getting controlled by OHA, should be properly counseled for GLP-1 receptor antagonist, because of the simple reason that we might have an additional impact on the reduction of breast cancer sort of recurrence. But also, sir, it is very important for the survivors also who are on endocrine therapy, who have weight gain, so as to speak, as a side effect, whether they can be sort of given these drugs and whether the same impact will happen in those drugs also. Because I think some research has shown that the impact of the drugs to reduce the weight may not be as significant when you are taking a concomitant hormonal treatment. So that is some area which requires research, in my opinion.
Perfect. So finally, again, question to Dr. M.V. Chandrakant, that whether should oncologists manage this GLP-1 RS directly, or there should be a referral pathway to endocrinology be established?
So once there is evidence that this reduces cancer risk or it has anti-cancer activity, so why it should be an oncological domain.
Perfect.
So we can manage it effectively.
Very good answer. Because my wife is endocrinologist, so I cannot tell such type. Dr. Kausal, should oncologists manage this directly?
Yes, sir, we can manage it, but we should be in collaborations with the endocrinologist.
So my second slide is navigating the toolkit. That what are the key safety consideration when using? So Dr. Rohit Pai, your point is sometimes. So what you feel that what should be the key safety consideration if we using GLP-1 RS?
So, sir, quite frankly, I think they are reasonably well tolerated drugs. I think they are very commonly used drugs. So, I don't think that obviously, sir, we should look at drug interactions, etc., use of concomitant anti-cancer therapy, etc. And most importantly, we should not start them with chemotherapy or with the active anti-cancer treatment. I think that is also there is some discussion which I think it might attenuate the impact of chemotherapy. So, GLP-1 receptor agonist probably may not be the way to go to start too early. And what I feel is, even though as oncologists we can manage, I think if we are using GLP-1, etc., I think we should involve a metabolic person or endocrine person in our team, because it's an ongoing sort of decision. How long will the patient would be on the treatment, and how when we should stop, etc. And if the patient is not tolerating, so I think it's better to have a team. That is what I feel.
Perfect. Dr. Vijay Setti, your comment on safety consideration or whether oncologist domain or a endocrinologist domain? Dr. Vijay Setti, please.
I beg to differ from Dr. Chandrakant. I think it should be with endocrinologist. I think, sir, you should give it to your better half. We are having enough and more load with the newer drugs and newer destiny trials. So I think we'll be overloaded with our own drugs, and I think better get the endocrine on board. Also, to add about the safety consideration, it has got actually by itself, it has got neuropsychiatric side effect as one problem, and more important, and they have severe gastroparesis. I think that is one contraindication as well. So I think these are some things which we should keep in mind before we prescribe a GLP-1 agonist. Having said that, I think with more expertise, probably we'll be using it if the patient does not want to see endocrinologist. But I think it's always better. I agree with Dr. Rohit. I think we should form a team, and endocrinologists need to be involved. I feel solo medical oncologist, it doesn't make sense for us to get involved with too many complicating drugs.
Dr. Syam Rathi, the third question is what is the optimal timing for introducing in oncology practice? Dr. Syam Rathi available or Dr. Animesh Agrawal?
Dr. Shyam is not available.
Okay. Dr. Animesh Agrawal?
No, sir.
Okay. So the third question again to Dr. Chandrakant, what should be the optimal timing?
So I'm not sure as of now. I think so it can be safely given even with anti-cancer therapy. So the interference is not much, but yes, it reduces appetite. It may cause more weight loss. So in advanced cancers, I think we need to be careful, but in early cancer should be okay. So these are safe.
Perfect.
Pancreatitis is one that's quite rare. So we need to just have a watch.
So I
Appetite
think
is
the
an
next
issue.
slide tells the metabolic intersection, and I think my answer of this both question is that hyperinsulinemia and chronic low-grade inflammation definitely drive the breast tumor proliferation. Or do GLP-1 RS have a direct tumor suppressive effect? Dr. Kausal?
So most likely to be the metabolic effects rather than direct tumor suppressive effect.
Correct. Dr. Again, Dr. Vijay Setti?
Yeah, I agree with Dr. Kaushal. It's more to do with the metabolic effect rather than a direct tumor suppressive effect.
Perfect. So is there evidence is supporting the differential effect across breast cancer subtypes? I think is across all the breast cancer subtypes. And do GLP-1 mechanism have greater relevance in ER positive disease versus TNBC? I does not think that ER positive or TNBC have different mechanism. So I think they both are relevant, or both subtype have relevance of this GLP-1 mechanism. The future direction, I think all are also still agree that prospective trial, or there are some trials should be done also to define the role of GLP-1 in breast cancer, and real world evidence support the future clinical practice. Yes, my answer is yes. Thank you very much. Over to organizers. Over to Dr. Ashok Vaid, sir.
Thank you, Dr. Bhavesh, and thank you so much, all the panelists. That was a wonderful discussion, so much learning. And as we come to the end of the program, I think a couple of things stand out.
So we have one more talk, the last one.
Oh, sorry, my apologies, my apologies. Then let's complete that. Yeah, sorry.
Okay. So for our final scientific presentation, we turn to precision oncology in metastatic breast cancer to share insights from the SERENA-6 and DATO-DXd studies. Please welcome Dr. Sachin Gupta sir from Chandigarh.
Sachin,
Over
my
to you, sir.
apologies for skipping. Thank you. Please go ahead.
Very good evening, sir. Thank you for having me here. And I'm not putting my video on because my signals are also not that great here. I hope my slide is visible.
Very well.
Yeah. All right. So I know I'm keeping you away from dinner, so I will be very quick. And so my task is to take you through SERENA-6 and the trials for datopotamab in metastatic breast cancer. And so since this webinar is about precision oncology also, so this is precision oncology at its best, because SERENA-6 was a phase 3 trial of ctDNA guided switch to camizestrant, which is an oral SERD, along with CDK4/6 inhibitors versus continued AI plus CDK4/6. So we are watching ESR1 mutation emergence here in hormone receptor positive advanced breast cancer. So we also know that ESR1 is uncommon in diagnosis, but emerges during treatment in nearly 40% of these patients. And so these mutations can be detected in ctDNA liquid biopsy before the actual clinical progression. And there is another trial, PADA1, which showed switching to fulvestrant, which is an injectable SERD, plus pelbo upon ESR1 mutation detection, so which is a similar kind of strategy. So this significantly improved PFS. Now this drug is an oral SERD to inhibit and degrade both wild type and mutant estrogen receptor. And current analysis tested this hypothesis with camizestrant. So this is the trial design. So patients with advanced breast cancer, hormone receptor positive, who received more than 6 months of first-line AI and CDK4/6. So either of these three CDK4/6 inhibitor all were allowed. And ctDNA detected ESR1 mutation with no evidence of disease progression, this clinically, radiologically. So now, so this camizestrant was added and continued. CDK4/6 inhibitors were retained. And in the other arm, we of course continued AI and CDK4/6 inhibitor until disease progression, death, toxicity, or withdrawal. So the baseline characteristics were well randomized. So these are some of the common ESR1 mutations here. And so majority of these patients were on palbociclib. And so this is the PFS difference. So median PFS 16 versus 9.2 months, and the hazard ratio is 0.44. So if you purely look at the PFS, why this strategy is making a difference. And this is the PFS by subgroup. And again, the hazard ratios are pretty good for all the subgroups across race, age, menopause status, disease sites, all the CDK4/6 inhibitors, and time from start of AI, and the type of ESR1 mutation. And so this is the safety thing. So not many discontinuations, and these are the some of the most frequent adverse events. And grade 3 events, mainly we had neutropenias and some anemia, otherwise pretty well tolerated. So this is the update where we have PFS and PFS2. So this switching to camizestrant improved TFST as well as TSST and profound reduction in ESR1 mutation allele frequency versus the continuation of AI and CDK4/6 inhibitors. So the hazard ratios are 0.46, 0.56. So it's quite an impressive thing. And to conclude, the switching to oral SERD with emergence of ESR1 mutation, it provides clinically meaningful PFS improvement of more than 7 months versus the continuation of the same drugs. And also further improvement in PFS2, TFST, TSST, and also the chemotherapy ADC free survival. So, and well tolerated drug. And so that was about Serena 6 camizestrant. And so now coming to the Dato-DXd, standard systemic chemotherapy toxicity. And but it does have some toxicities like stomatitis, nausea, and namely ocular toxicity is quite unique, and ILD is rare, but it's an important toxicity to be seen. Now there is another drug in this space which is sacituzumab govitecan. Again, our target is TROP2, but the payload is different here, and the side effect profile is also different, with diarrhea, neutropenia being more common with SG. And so now the Dato-DXd studies are named by Tropion. So this is Tropion pan tumor 1, which is in heavily pretreated hormone receptor positive as well as TNBC population. And still it showed response of nearly 30-35% with 6 milligram per kg dose. So this established this TROP2 ADC therapy in this particular state in heavily pretreated patients. So then we have further studies. So now one of them is Tropion breast 01, where Dato-DXd was compared with investigator choice chemotherapy, which could be eribulin, capecitabine, vinorelbine, or gemcitabine. So again, these patients were hormone receptor positive, metastatic, progression after endocrine, and also chemotherapy. And even in this highly pretreated population, it showed some good median PFS benefit, and with hazard ratio of 0.63. And so this became a sort of a new standard for tolerability, and so significant PFS improvement with the lower severe toxicity and superior quality of life. So this another drug was added to these patients who were not benefiting with hormonal agents and also some chemotherapy. So now in TNBC, so these are patients in whom PD-1, PD-L1 inhibitor is not appropriate. So for metastatic setting, we know if PD-L1 is negative, then addition of immunotherapy doesn't benefit here. So now these patients were randomized to Dato-DXd and chemotherapy. And again, the median PFS benefit 10.8 versus 5.6, OS 23.7 versus 8.7. So this showed some benefit there as well. And so in TNBC space, we had this drug where immunotherapy could not be used. So now there are other studies, Tropion 0, 3, 4, and 5. So 3 is for first line hormone receptor positive, where now this strategy is being combined with durvalumab, and so versus CDK4/6 and this. So can this ADC benefit in the first line? So we are answering this question. And then endocrine resistant space, where Dato-DXd plus endocrine therapy versus chemotherapy. And breast 05, where PD-L1 positive TNBC. So here it is being combined with immunotherapy again. And the comparator arm is the standard Pembro plus chemo. So this is for PD-L1 positive. So can a chemo-free ADC IO outperform the current IO chemo arm? So this is the question being answered here. So for hormone receptor positive, so this is leading to a significant PFS and higher response rates, but no confirmed OS advantage. But still, it offers a another treatment regimen. And for TNBC, we see significant PFS, OS benefit, and response rates, and could be a standard of care options where PDL1 inhibitors are don't fit in because PDL1 is negative. So this would be some practical positioning here. So for hormone receptor positive, after failure of endocrine and chemo, this is an option. TNBC first line where immunotherapy is not in ineligible patients, again it can be an option. And rest, it's under investigation in other areas in Tropine 03, 04, 05. So I think this is what I would like to summarize. So this is some repetition here, right? And of course, since we have sacituzumab also here, and how do we sort of use these drugs in sequence? And also there would be patients who are HER2 low, where TDXT is also an option, whether they are TNBCs or hormone receptor positive. So now these are some competing strategies in this set of patients. But how do we sequence them? Maybe we still don't know, and that is we can debate on that. I think I'll just stop here and
Thank you, Dr. Sachin, for bringing out the point about the ADCs and especially the Dato-DXd to the forefront. And Dr. Khushi, and anything from your side before I wrap it up? And
No, sir, it has been done. Just
thank
word
you
of
so much.
thanks from
And
your
we
end.
acknowledge the presence of Dr. Rajesh Gupta, senior physician, who is a special invitee. Sir, if you would like to, you have seen the proceedings as a totally neutral and a third party and seen where oncology is headed. Would you like to offer any comments about where we are? It'll be great to hear from you. And Dr. Sanjay, from you as well,
Sure, sure, sir, sure. So, first of all, I would like to congratulate all the eminent speakers and the faculty members who made these sessions very exciting, especially looking at the recent trials, the recent mountain of data, as Dr. Vaidya has rightly pointed out, and just taking the crux and how this would be really translating into real life practice is very much thought provoking after listening to all of this, especially, the GLP-1 receptor antagonist. So there, when on one side, when we are talking of cancer patients getting cachexic and losing a lot of weight, and the other side we are also looking at the place where we are trying to reduce the weight of the patients in cancer patients. And of course, the second talk wherein uh, it was seen how one can do away with chemotherapy, rather, wherein that was about the Sinomac trial update, which was the genomics, the genomic Optima trial, how one can do away with the cancer chemotherapy. And so a lot of thought-provoking questions that comes to mind when such genomic studies are available in India, and if not, when they would be available. So many things. So wonderful sessions throughout, and of course, last not but the least, Dr. Sachin Gupta really made it. Even with the limited time available, he demonstrated a lot of studies and could wrap up the things very fast. So I may have missed many of the other eminent speakers over here, but a lot of appreciation from our side to all of the faculties who made these sessions very wonderful and exciting and as well thought-provoking. So that was from my side, sir.
Thank you. Thank you for your kind words and your wrapping up about this. So, ladies and gentlemen, we do agree that one size will not fit all. And breast cancer has now become a group of many, many diseases. And when we were assimilating this program, I thank Rajesh, hats off to him, how he could dissect out these abstracts and bring them up on this wonderful program. And the GLP story is something very, very exciting. When we were discussing, this came as a first choice that we should discuss this. And the point has been discussed very elegantly. So many things have been brought out. And we know that de-escalation, genomics, the ADCs, Dr. Sachin very elegantly showed that in breast also, we are now talking of a chemo-free regimen. And that's a big, big leap. So, of course, the challenges with us will be that these drugs are going to be expensive, and how we incorporate and adopt in our day-to-day practice would be a challenge. And SERDs, also as presented by Dr. Sachin, is the new story. And we are seeing that the genomics is actually shaping up things. And in the ESR1 story, genomics is again playing a big role. And the story about curcumin we heard, very interesting, and we definitely need a phase 3 trial. I have the pleasure of thanking Rajesh, Dr. Khushi, and Anshika and their team for putting up this wonderful program, which culminated in more than 250 registrations. And we had at one point in time 214 people from all across India and from all across the globe, more than 10 countries from where people had logged in, and ranging from the Middle East, even UK, Bangladesh, Mexico, and many other parts of the world, which is a big tribute to their campaigning and spreading the word that such a program is on. Dr. Rajesh, many thanks for joining. Samarth team, Om, and Dr. Sanjay for sponsoring this activity. You are the champions, and you've been supporting these activities for more than 5 years now. And last but not the least, to the attendees, to the joinees, faculties, presenters, moderators, everyone. Thank you so much. Rajesh, do you have something to say at the end? Thank you so much.
Thank you very much, sir.
Thank you. Thank you so much. And we close the program. Look forward to another exciting program, and I'm sure we'll come up with something unique and something more exciting next time. Thank you so much. Good night. Take care. See you soon. Back again.
Sir.